Hi, everyone. My name is Tim Brotherton. I'm an internal medicine resident at St. Louis University Hospital in St. Louis, Missouri. This is a case of a gastric glomus tumor in a patient that was diagnosed by upper endoscopy. My co-authors on this case are Jabran Kanizer, who is one of our GI fellows, Irfan Yassin, one of our pathology residents, and Dr. Mike Jockman, who is our attending on this case. A little bit of background information. Gastric glomus tumors are benign tumors that result from cells of the glomus body. And when they occur in the stomach, they typically occur in the submucosal layer. They're very difficult to diagnose as they lack any specific symptoms, clinical features, radiographic or endoscopic findings. Our patient was a 44-year-old woman who was referred to GI clinic for evaluation of her chronic abdominal pain. She was treated with conservative measures first, including laxatives and fiber for any component of constipation. However, there was no improvement with these measures, so it was decided to proceed with an upper endoscopy. Her EGD showed a 1.5 centimeter umbilicated gastric tumor located in the greater curvature of the stomach. You can see images of that tumor from the endoscopy in figure 1, which is at the top of the poster. You can see the umbilicated appearance and actually that the tumor was oozing blood during the endoscopy actively. Now, grossly on endoscopy, this was thought to most likely represent a gastrointestinal stromal tumor. However, to everyone's surprise, the pathology ended up being most consistent with a gastric glomus tumor. We have several images from the pathology in the middle of the poster. First, in figure 2, part A, you can just see a general overview of the pathology, which is described as a epithelioid but syncytial appearance. In other words, cells resembling epithelial cells that are all pushed together. In figure 2, part B, you can see some red arrows pointing to areas of hemorrhage on the pathology. It makes sense that there be hemorrhagic areas as the glomus body from which this tumor is derived, actually its main function is to serve as arteriovenous shunting. And then in C and D, there's a couple of special stains that were utilized by the pathologist to ultimately confirm that this was indeed most consistent with a gastric glomus tumor on the pathology. A CT scan was, of course, obtained, and you can see a couple of slices from that CT at the bottom of the poster. It showed a 2.2 by 1.8 by 2.0 centimeter submucosal mixed density and well-circumscribed mass along the greater curvature of the stomach. There is an orange arrow pointing toward that tumor on the CT scan there at the bottom. And moving on into our discussion, glomus tumors themselves typically don't occur in the stomach. They typically occur in the upper extremities, and more specifically, they have a predilection to occur in the subungual region of the finger, or in other words, underneath the fingernail bed. Overall, gastric glomus tumors, so glomus tumors that occur in the stomach, represent less than 1% of all soft tissue gastric tumors, with gastrointestinal stromal tumors being the most common. While it is possible to diagnose these on upper endoscopy, such as in our patient who was accurately diagnosed by upper endoscopy, it's very difficult as the tumors are submucosal. Therefore, it's hard to get an adequate biopsy specimen just from a traditional endoscopy. And many of these patients, actually most of these patients, require either an endoscopic ultrasound with fine needle aspiration or even a surgical pathology from resection to confirm their diagnosis. Our case highlights two important points. First, our patient was indeed accurately diagnosed by EGD with conventional biopsy, which may have been due to the atypical growth pattern of the tumor. You can see it's very clearly protruding into the gastric lumen, so this likely allowed for our endoscopist to more easily access the tumor and obtain an adequate biopsy specimen. Second, that protruding appearance is atypical for this type of tumor, so it's important to remember that it can manifest in many different ways on upper endoscopy. For the general internist, this case highlights the importance of referring to gastroenterology for patients who have persistent abdominal pain of unknown etiology so that they can potentially undergo an upper endoscopy if indicated that might end up being diagnostic for them. Thank you very much for your time.